I'd like to welcome all of you to the first talk in the bariatric series. The team at Surg Kuwait were kind enough to invite me for a second talk this year, and it's always a pleasure and an honor to be a part of this initiative. This series will be covering four main bariatric topics. The first being this one, planning bariatric surgery. There's going to be another talk about bariatric pathophysiology by Dr. Khalid Zamil, a third talk about bariatric emergencies by Khalid Al-Yagout, and the last talk about the techniques of bariatric surgery by Dr. Khalid Al-Anizi. I just realized I'm the only person not named Khalid in this series. And then following that, there's going to be an online Gulf Obesity Surgical Society conference online as well. So hopefully these topics will be a nice introduction to the conference. So I'm just going to share my screen now. Okay, so preparing patients for bariatric surgery, keys to success. And of course, I'm Dr. Sulaiman Al-Mazidi. I'm a specialist bariatric surgeon. I got my bariatric training in London, the UK, at Chelsea Westminster, and I also have a fellowship in colorectal surgery. So, I know from what I understood is most of the participants today are surgeons or work closely with surgeons. And I start off with this picture because generally speaking and traditionally, we've been taught that surgeons, they're the superheroes of the hospital, the lions of the hospital, as they say. And this, of course, obviously is very wrong. Most of you have either learned this the hard way or you found out as you grow up that the surgeon alone can do nothing in the hospital. All of the different specialties, they complement each other. And just to show you, to give you an idea, if surgeons were the lions of the hospital and worked alone with no help, this is how we would be doing surgery today. So this is an amputation, of course, without anesthesia, without medical help, without anything other than the surgeon, and you can see how difficult that is. So this all changed when Dr. William Morton, the anesthetist who used to give patients ether and successfully gave this patient in this picture who had some dental issue the first anesthesia. So when this happened, he approached surgeons at Mass General Hospital in Harvard back in 1846. And obviously, as with all other stories, everyone laughed at him. First they said, no, this is a joke. But he told them to try it out, and they did in 1846. With Dr. John Warren, who was the head of surgery at Mass General Hospital. And in this picture was actually taken 1 week after the original surgery. This is a reenactment, because during that surgery, they successfully anesthetized the first patient in the world to remove a lump on his neck. So this is a reenactment of that surgery, but this is when they made history. And as you can see, a surgeon alone could not have done this. And it brings me to my last point before we start the talk. Unity is strength, okay? Something that I learned in my humble career is there is no one more important than anyone else in the hospital. Surgeons are as important as the anesthetists, they're as important as the medical doctors, as important as the cleaners and porters. And respect is the most important thing, I think, in a healthcare organization. It's something I really find annoying as a surgeon, is looking at other surgeons scream and shout in the operating room or speak. They degrade other doctors over the phone during consultations. This is extremely unhealthy behavior, and I really hope that this talk will show you how important teamwork really is. So, this famous picture, I'm not sure, we have visitors, listeners from all over the world, but in Kuwait, I can tell you, you don't become a real bariatric surgeon until you post this on your Instagram. After you post this, it's your degree, your fellowship degree. So everyone wants to reach this. taking stomach. Of course, we have the patient's agreement, consent to put this picture, and putting the staples in the background and saying, عملية تكميم, come to my clinic or whatever, and I'll do this surgery, you lose weight. This is the easiest bit. Doing the surgery, I can teach a monkey in a week how to do a sleeve gastrectomy. It's a very simple procedure. But the planning phase, which has to start months before surgery, is what will determine the outcome and make sure the patient has successful surgery. So I was very lucky to present this talk now because a few months back, the American Society for Metabolic and Bariatric Surgery published their updated guidelines. So this was published in 2020. So just this year. And it's basically clinical guidelines for bariatric procedures. This was a joint effort by the ASMBS with the American College of Endocrinology, American Society of Anesthesiologists, and the Obesity Medicine Association. So it's a very extensive group of guidelines, and I'm going to speak about the parts related to preoperative optimization today. So to note, the guidelines that I'm going to present today, when they speak of bariatric procedures, and I'm sure Dr. Khalid Anizi will get into these details later on, but the bariatric procedures that are recognized in these guidelines are only 4 procedures, which are here. So the Roux-en-Y gastric bypass, which until today is the gold standard bariatric operation, the gastric band, which is losing fame, the sleeve gastrectomy, obviously the rising star, and the biliopancreatic diversion with duodenal switch, which is not as famous as the others, but has its own indications. So this paper published by the team at Cleveland Clinic back in 2014 shows you the trends in bariatric surgery. So since the beginning, the bypass has always been the queen of bariatric surgery, making up a good proportion of the surgeries. The VBG, the vertical banded gastroplasty, is now an obsolete surgery. It used to be done back in the 90s. You can see there was a rise in the band and then a dip again because a lot of these patients did not achieve successful weight loss. And as most of the surgeons know, going into an abdomen after a band is a war zone. It's a disaster. Very difficult. And then the sleeve that started in the early 2000s and then picked up is now today the most commonly performed bariatric surgery. It is still not the gold standard, but it's definitely the most common and definitely most common in Kuwait. So first and most importantly, so these following slides are all from the ASMBS guidelines, okay? Who should be offered? And these are the same guidelines that we use in Kuwait. So BMI above 40, definitely an indication. BMI above 35 if they have one severe obesity-related complication. And these are the definitions used for the ORCs by the ASMBS. Very similar to the Kuwait definitions. So type 2 diabetes, poorly controlled hypertension, fatty liver, obstructive sleep apnea, osteoarthritis, or urinary stress incontinence. What you do have to note is in different countries, the definitions for BMI and obesity are different. BMI is an arbitrary number. Okay, there's no scientific evidence to say that BMI above 40 is morbid obesity, above 35 is obesity, is grade 3 obesity. This is a number that was made up, okay, by surgeons and whatever in the 20th century. So different countries around the world now have their own definitions. In India, for example, in Asia, above 25 is sometimes considered obese and an indication because they found out that there's a higher chance of a complication if BMI is above 25. So it's different around the world, but Kuwait follows the US definitions. So ideally, a patient who meets the criteria should not be seen by a surgeon in the beginning. In Kuwait, the system is, I'm not sure about the other participants, but in Kuwait, a patient is referred directly to a surgeon. This is a disaster. It shouldn't be happening. A surgeon should be what we call tier 4, so level 4 service. If the patient fails to lose weight in the first 3 tiers, only then does he or she need to see a surgeon. And this is something that we're trying to focus more and more on in Kuwait. But for the sake of this presentation, we're going to assume this is either a surgeon, a primary health professional, or a bariatrician who sees the patient, or even a dietitian. So definitely medical history is important with the obesity-related complications. You need to know what the cause of obesity is. There's a lot of genetic causes of obesity, so you need to ask about the family history. Of course, you need to measure the weight and BMI. You need to ask if the patient lost history in the past. Why did they successfully lose? Why did they regain the weight? What sort of diet regimens were they on? These are all very important. This will show you how much commitment a patient has. And I can tell you from my humble experience, if you can tell a patient from pre-operatively if they will lose weight or not. You can tell if they've been bouncing around different diets, not losing weight, trying different things and with no success. It is unlikely that they will definitely lose weight, but they probably won't reach successful results. And you need to make sure there's no surgical contraindication. Again, these are all the guidelines from the ASMBS. So psychosocial history, very important, we'll talk about later. Physical examination, and you need to discuss with the patients the risk and benefits of surgery. The patient needs to know this is not a magic wand and they'll suddenly wake up being 50 kilograms lighter. There's definitely risk. This is major surgery. They need to know about the procedure options. Sleeve gastrectomy is not the only option. There are so many other options, and the patient needs to know what their options are. They need to know that they have to be on vitamin supplementation and follow-up for life. All the latest guidelines say patients have to be on multivitamins for life. It's not an option anymore. Finally, they need to know the relevant financial information. Of course, this is from the ASMBS. So in America, obviously, this is a big issue. In Kuwait, you do have to mention to all patients that the surgery, in the ministry at least, is for free. However, the patient needs to pay for the equipment. So again, this is an important issue that should be discussed with them. What laboratory tests should be done? Different hospitals around the world have different protocols. There's people who order vitamin A, vitamin D, vitamin C. The guidelines say you do a CBC, lipid profile, fasting blood sugar and HbA1c, kidney liver function, coag profile, iron and folate studies, vitamin B12 and D. That's it. That's all you need to do. This list is long by itself, but currently most of the hospitals actually do things like vitamin B6 and thyroid function for all patients. These need to be tailored. You do not need to do them for all patients. The patient then, or in the beginning, needs to be seen by a dietitian or nutritionist. You should not wait until post-operatively to send a patient to a dietitian or nutritionist. It's very important. The patient needs to be seen and optimized beforehand. So why do they need to see the nutritionist or dietitian? Number one, all the patients need to lose weight before surgery to reduce liver volume, especially those with fatty liver. When I was working in the UK, the NHS provided bariatric surgery for free for their patients who met the criteria. However, in order to be eligible, patients had to be in a program with a dietitian for 1 year. So they had to stay for an entire year. They had to lose around 10% of their weight in order to be eligible for surgery. I'll talk a bit later about how we did this in Kuwait, but again, it's very, very, very important. Educational material, the patient need to be educated. They need to have their own brochures at home so that they know what to do. There needs to be a lifestyle evaluation. Some things that doctors, each person has their own specialty, and to be honest, most doctors don't know how to evaluate lifestyle, especially when it comes to eating properly. So there's things like the Healthy Eating Index. If there's any dietitians listening, I'm sure they know it. They need to ask about cardiovascular fitness and strength training, which is something that Surg Kuwait recently alluded to in the past few lectures about the importance of being fit and healthy. And the same thing goes with the patients. They need to know what sort of exercise they need to be doing afterwards. Now, endocrinologists. So what's the role of an endocrinologist in preoperative? So patients who are diabetics, obviously, you need to reach a target HbA1c of 6.5 to 7 before proceeding to surgery. If there's any clinical evidence of hypothyroidism, then you order a thyroid function test. For females with PCOS, you can send some androgen tests, and then if you suspect Cushing's syndrome, they can also do some screening for that. Anesthesia, again, this is all done preoperatively, ECG based on the risk factors, obstructive sleep apnea. It's very important to screen. There are a lot of screening protocols that are employed. You can easily search online and apply one in your hospital. And if the patient screens positive for obstructive sleep apnea, you have to refer them to a respirologist for sleep studies beforehand. Most importantly, smoking. So smoking should be avoided at all times by all patients for any surgery anywhere around the world. This is beyond doubt. However, if patients are smoking, preferably they should quit smoking cigarettes 1 year before. Most patients will not do that. So the least you can do is tell them to quit smoking at least 6 weeks in order to reverse the physiological effects on the lungs. The patients have to know, especially patients who undergo Roux-en-Y gastric bypass, that if they continue smoking, there is an increased risk of developing complications such as marginal ulcers, which can perforate. So they have to be aware of that. Another thing that is very important but is often overlooked, especially in our region, is counseling females. So the females undergoing bariatric surgery, they have to know that with weight loss, their fertility will improve. So they do on the most part. There are a lot of studies today showing that even male fertility improves after bariatric surgery. So they have to make sure that they know that they shouldn't get pregnant from 12 to 18 months, so that for the first year and a half after surgery. You have to tell them that. If they do get pregnant, they will need to be monitored closely to make sure that the fetus is healthy. The patients should be counseled. I know this is a very difficult topic, especially in the Arab world, but it is very important. If you feel uncomfortable, you find a female doctor to tell the patient to sit down and refer them to a gynecologist, anything. But you have to mention to them that they need to be on contraceptives, and you have to make sure that all the options for contraception are known to them. If the patient is going for a bypass, you have to tell them that oral contraceptive absorption might be altered, so they might resort to other means. And patients who are on the contraceptive pill need to stop it for at least 1 month, so 1 cycle before surgery, to avoid DVT. Psychology. This is something that not only is sometimes overlooked, but is always overlooked. And I speak about Kuwait here. So every patient needs to have some sort of evaluation by a qualified behavioral health professional. This can be in the form of surveys to look at levels of anxiety, depression, suicidal ideations, as well as eating disorders. They need to be the family, the environment. These patients, especially the younger patients, they will go home, and it's the family who will take care of them. So the family needs to know what the appropriate measures are for this patient. If there is a suspected psychiatric illness, substance abuse, or dependence, they need to be referred to a psychiatrist. Why is this important? Things like alcohol consumption, for example, they should be, especially in high-risk patients, they should be stopped altogether, especially after Roux-en-Y gastric bypass. The absorption will be at least twice as much in a bypass patient compared to a normal patient. And there's recent evidence that alcohol absorption also increases after a sleeve gastrectomy. So now we're done with all the things that primarily need to be assessed. The surgeon can then see the patient, go through the same things. 2 things that the ASMBS talk about and are relevant to Kuwait, and I'm sure most of the participants: preoperative endoscopy. should you do it routinely or not? So if the patients have significant GI symptoms, reflux, upper abdominal pain, or any GI bleed, they could either have imaging studies, an upper GI series, or an endoscopy. So again, it's at the discretion of the surgeon, and these are the guidelines. However, they do suggest that specifically for sleeve gastrectomy, that endoscopy should be considered in all patients, simply because most of the papers published currently about routine endoscopy are for sleeve patients. So this was added this year. In the last guidelines by ASMBS, this wasn't there, but they added that for sleeve gastrectomy, you should consider endoscopy for all patients. And I put the picture here of the intragastric balloon because this is something that personally happened to us. A patient was going to undergo a sleeve gastrectomy. They did not give history of previous balloon insertion. On the day in the hospital, some surgeons, they do on-table pre-op endoscopies, and that patient was lucky that that surgeon was doing an endoscopy. And he found an intragastric balloon still in the stomach. The patient was then woken from anesthesia, and then he informed the surgeon that he had inserted a balloon more than 5 years ago and thought that the balloon had fallen out by itself. Again, there was another surgeon just last week who posted on their social media account of the same exact story happening to him in his private clinic. So this is something rare, but it's something that does happen. And personally, I perform endoscopy on all patients pre-op, not just for balloons, but to make sure there's no other issue going on. So ultrasound, again, in Kuwait, we routinely perform an abdominal ultrasound on all patients. Most people believe that the ultrasound is for assessment of gallstones. On the contrary, it is actually for the liver. Gallstones, whether they exist preoperatively or not, really doesn't matter with a sleeve gastrectomy. You generally do not need to remove the gallbladder because the chance of patients developing a complication is extremely rare from the gallstone. For a bypass, it's different. You should offer patients a gallbladder removal. However, more importantly, ultrasound is used to assess the liver. So fatty liver can make the actual surgery very, very difficult. Sometimes you have to abort surgery from a fatty liver. And this is just for your knowledge. If you want to do ultrasounds and see some patients for yourself, just to try it out, the way you detect fatty liver is you look at the echogenicity of the liver compared to the kidney. So the liver and the kidney should be isoechogenic. However, when there is marked fatty liver, the liver is more hyperechoic, and the kidney, you see it, is hypoechoic. So for the non-doctors, the kidney is darker when there's fatty liver. And why is it important? So we published a paper back when we were working in Amiri, and in the beginning of sleeve gastrectomies, all the patients used to have preoperative ultrasounds. So we looked at 84 patients who were diagnosed with fatty liver before surgery, and from those, 56%, so more than half, had complete resolution post-operatively with the weight loss. And we found that patients who lost more than 50% of their excess weight had significantly higher chance of achieving resolution of their fatty liver, and you can see by the diagram below. So these are the guidelines. So these are the things that are mentioned by the top 4 medical and surgical societies in the United States, and this is ideal. I can tell you right now that 99% of the places around the world do not go entirely by these guidelines, unfortunately. But, and I'm sure most of you, especially those working in Kuwait, right now you're thinking, this is impossible, this will never happen. There's just like this guy in the picture, there is no way, I feel like that's what he's saying, there is no way I can do this in my hospital. So we all used to think the same thing, and I'm going to prove to you in the next set of slides that not only is it possible in Kuwait, you can actually reach international standards, if not beat them, in Kuwait. And for this, I'm going to give the example of what we did in Jabr Hospital. So in Kuwait, what happens is, this is what happens. A patient comes to the surgeon directly. The surgeon asks the patient, what are you doing tomorrow? The patient says, nothing. He says, okay, do your labs today. We'll do your sleeve gastrectomy tomorrow. Patient does the surgery, is lost to follow-up. They get into malnutrition, vitamin deficiencies, an endless vicious cycle of complications. This, of course, is completely wrong. Why shouldn't this happen? So the entire world now is living a multidisciplinary approach to all the medical issues. Why is it important to have a multidisciplinary team, especially in bariatric surgery? There is a paper published in 2019, Obesity Surgery, and they found that just having one MDT preoperatively changed the patient's decision making, so the decision of the main surgeon who wanted to do the surgery. For 45% of the patients, there was disagreement in the MDT. And after a discussion, the optimal form of treatment was reached. So imagine, they always say two heads are better than one, and I really believe it's true in this situation. So this is the pathway we created in Jabr Hospital. Unfortunately, the system in Kuwait still, at the moment, the polyclinics refer any patient who meets the criteria directly to the surgeon. We're trying to change that at the primary care level. So right now in Kuwait, there are a few primary care physicians who actually have fellowships in bariatric medicine and who have returned to Kuwait. They're trying to set up clinics in the polyclinic so that this can be done there instead of the surgeon doing it. So what happens in Jabr Hospital is the patient comes to the surgeon. As a surgeon, I do not mention anything about the surgery to the patient. We do not discuss the procedures. We do not discuss when the surgery is going to be done or if the surgery is going to be done. We simply give the patient an introduction to the bariatric pathway at our hospital, and the patient is directly referred to the bariatric coordinator. The bariatric coordinator in our hospital is Dr. Mail Hazzah. So she's a medical doctor with a PhD in clinical nutrition. So she's a clinical nutritionist, and she is the main person. She's like the hub who sees every single patient, along with her team that I'm going to be talking about now. They see all the patients, and then they send it, and then they write the patient's information down, and they send the patient to see the bariatric physician, Dr. Mohammed Al-Ajmi. So he's an internal medicine specialist who specialized in bariatric medicine. They see the clinical nutritionists, they see the surgeon at the end. Every single patient is screened psychologically in Jabr Hospital. There is no patient who can be allowed to undergo bariatric surgery unless they are seen by our psychologists. And this is something that I'm very proud of, actually. All the patients have to attend an educational class before surgery. This is the class given by our team, which I'll talk about now as well. And again, we also have the anesthesia. And all of these teams, we meet every other week in an MDT. So every other week, all of the new patients, we sit in an MDT and we discuss every single patient. When the MDT agrees on which patient should undergo surgery and the type of surgery, only then is the surgeon given the green light to proceed. If the clinical nutritionist thinks that this patient is not ready, if the psychologist thinks that this patient needs more psychological workup, there is no way that surgeon is going to be doing the surgery in our hospital, at least. They can do it anywhere else in Kuwait if they want. And recently, we've added the plastic surgery. So Dr. Sara Liuha has joined our team. This is going to be important because most patients end up with skin redundancies after surgery. So we need to assess what patients need what sort of body contouring after surgery. So I talked about this briefly. So why is an MDT important? It's always, as I said in the beginning, unity is strength. The more people you have, the better the the results of the decision making are. Very much like a democracy. Maybe not all democracies, but let's say most successful democracies around the world. Preoperative optimization, individualized care, revisional surgery is a very big topic these days. And again, MDTs are very important in deciding which patient should undergo which type of revisional surgery. So this is a picture of our MDT. So it happens every other week. We discuss every single patient. We have doctors from, you can see here we even have our professor of genetics, Dr. Ahmed Al-Sirri, who joins us in our discussions. So this is Jabr Hospital. For those of you who are not from Kuwait, or for those of you who live in Kuwait who don't know what's going on in the news, this is Jabr Hospital. It's biggest hospital in Kuwait and the Middle East. It's the 7th biggest in the world in terms of bed capacity. There's around 1,200 beds. It opened very recently. It's got 150 elevators, which is a very interesting statistic. Car park is for 5,000 cars, 3 helipads. It's basically, it's a very big hospital. Okay. Recently, in the COVID pandemic, it's been converted into a COVID quarantine hospital. At one point, it did have 1,200 COVID patients. It's this, I believe, definitely in the region, but in the world, it was one of the highest concentrations of COVID patients in one facility. And currently, it's slowly going back. Currently, there's only 90 COVID patients there. So it's slowly turning back into a normal hospital. This is a picture of Jabr. Underneath all of this is a big parking lot. So this is a picture from our first MDT. Our first MDT was in March of 2019. So almost a year and a half ago. It was not easy to build the team. It was not easy to get approvals. The most difficult bit, believe it or not, was getting a psychologist on board. And I'll talk about it a bit later, why it was difficult. So our nutritionists, again, I'm only going to be speaking about what happens before surgery. We have another team who see patients after surgery. So as I said, Dr. Mail Hazza, who is the clinical nutritionist and our bariatric coordinator. We have Dr. Ahmed Daghbasi, professor of nutrition, Kuwait University. We also have Professor Dana Tarrah and Maryam Al-Hamad. So they see all the patients before surgery. They take full anthropometric measures. They do full body composition analysis and start the patients on liver shrinkage diet straight away from the first day. And then they add the patients to the MDT list to be discussed. Why is it important to do liver shrinkage? Many papers around the world, but on average, a very interesting statistic, low-calorie diets, they reduce liver size by 2.4% every week. So every day counts before surgery to reduce the size of the liver. Preferably, it's recommended to do at least 1 month before surgery. So also in our MDT, we have an endocrinologist who is always with us, Dr. Thamar Al-Isa. He's the head of endocrinology. And what's good is during the MDT, a lot of times we don't know if we should refer patients to the endocrine team. Having him on board just on spot, he just tells us, do this, and that's it. The patient doesn't need to go anywhere. We also have 2 of Kuwait's most famous anesthetists, Dr. Abdurrahman Rafai, Dr. Ali Bandar, who are also with us in the MDT. And it's very important because a lot of times you refer patients to the anesthetists before surgery, and then they send them somewhere else, and they send them back to you. So during the MDT, we all sit down, and they tell us, okay, this patient needs to see the respirologist. This patient needs to have a neuro clearance, for example. So the patient doesn't need to bounce around 3 or 4 times. It's just one MDT meeting, everything is set, and the patient gets fast-tracked through it. So, as I said, the most difficult part in our entire MDT was getting a clinical psychologist to work with us. To be honest, it took us more than 5 months to get the approvals from the ministry to have a psychologist work in the Department of Surgery. We'd never had to use so much wasta in our life before, but it was worth it at the end. So Dr. Maryam Bul Hassan, she's our clinical psychologist. She works 2 days a week with us. She screens every single patient for eating disorders, anxiety, depression, suicidal thoughts before surgery. She sees patients and she follows them up afterwards. Also, whenever the patients flag as having significant psychiatric disorder, she sends them straight to the psychiatrists. And personally, I believe it was difficult not only because the paperwork was difficult, it was difficult for us to tell the patients that they had to be screened. So in the beginning, most patients were reluctant, and it was difficult to convince surgeons that their patients needed to be seen by a psychologist. And I can tell you, a lot of patients, they left our program because they thought it was taboo to be seen by a psychologist. But with time, the patients saw that those who, especially family members who underwent the screening, actually were better prepared mentally for surgery. And a lot of those patients came back begging us to be in our bariatric program. So, as I mentioned as well, all patients need to attend at least one educational class before their surgeries. The educational classes they're also held every other week in the evening times at Jabir Al-Ahmed Hospital. The team is led by Dr. Ahmed Sirri, who you can see in the middle, along with the rest of the team, Dr. Ahmed Duqbasi as well, and Dan Al-Tarrah and Maryam Al-Hamad. They give a talk to the patients about what to expect in terms of lifestyle change before and after surgery. And in the second half of the class, which is something I really, really like, our dietitians, we have their picture here, Iman Al-Awadi and Nada Saleh. They also give live cooking workshops for the patients. So all the patients, they have to, it's the second half of the educational class, they go through week by week how to prepare their food, how to cook their food, what food is allowed, what isn't allowed. And all the patients found that this was really, really helpful, because theory is one thing, but practically it's something entirely different. So I really applaud them for doing this. If you want to know more about the educational classes, you can follow them on Instagram at Jabir Education. One important thing we did as well is, as I said, educational pamphlets are very important. So we created 2 booklets. The booklet on the left is the Bariatric Nutrition Protocol. So it's for the healthcare workers. So if, for example, I get fired tomorrow, the whole team changes, everyone knows that they have to follow these protocols. It doesn't change. It's international guidelines about pre-op, post-op, vitamin supplementation, how much to take. You won't get any assistant registrars calling you asking what the discharge plan is, what the pre-op plan is. It's all there, and it's the same for every single patient. Standardization, that's all around the world. All the advanced centers, they standardized care for everyone. It's how you improve patient outcome. And on the right-hand side is the patient booklet. Every patient is given this booklet, and it really helps because it also tells the patient before surgery and after surgery each week what to eat. It's in both Arabic and English. And it really helped us during the COVID pandemic because most patients couldn't be followed up. So with this booklet, they had everything they needed in order to progress with their diet. So as a result of this, we actually applied and attained, became a center of excellence. So we were, I know a lot of people like to say the first, but this is real. We were the first metabolic and bariatric surgery center of excellence in any government hospital in Kuwait. This was given to us by the American Surgical Review Corporation. So a team from America, they came in. We had to go through a few days of extensive questioning and review, but we're very proud at the end to be the first center of excellence for bariatric surgery in Kuwait. It's really something that we're proud of. So finally, what's next? This has nothing to do with planning for surgery, but I just like to say this because I love robotics. I'm deeply in love with the Da Vinci. There are 2 surgical robots in Kuwait, and we were lucky enough to have one in Jabir Hospital. And we were also lucky enough to perform Kuwait's first bariatric surgeries just before the COVID pandemic. So we started in November. We did a few robotic bypasses. Dr. Muhammad Jamal did the first sleeve gastrectomy, and really all around the world, robotics is taking over. Currently, as of today in the United States, all of the hospitals, all the major hospitals have at least one surgical robot. It is slowly becoming the standard of care. And I personally believe that just as laparoscopic surgery took over open surgery back in the 90s, I have a very strong belief that robotics will take over laparoscopy. And I assure all of you, all you have to do is use the robot just once, and you will be convinced that you do not want to go back to laparoscopic surgery. So I really think that this will be the next big thing around the world, especially in Jabir Hospital. I don't see myself going back to doing any of these surgeries laparoscopically, to be honest. So finally, everything we said today is all about planning. As Benjamin Franklin said, if you fail to plan, you are planning to fail. And I really hope all of you, if you're juniors, that when you do become bariatric surgeons, you do make sure you follow international guidelines. You don't follow whatever you were passed down by generation, but you change where you're working, and you try to convince them through science and evidence that this is what's supposed to happen. It's going to be difficult, I assure you. I lived through one of the most difficult times in the surgical evolution of Kuwait. It's not easy at all, but it's not impossible. And I clearly showed you in these slides that if you try hard enough, it took us around 1.5 years of constant work. We were doing nothing else. Dr. Salman al-Sabah and I were doing nothing else other than focusing on getting a center of excellence. And if you try hard enough, there's nothing that you can't achieve. If you want to follow us also on Instagram, this is a Jabir Surgery Instagram account. And thank you very much. I'm not sure if Jude is back or not, but I'm going to stop sharing my screen and I'm going to answer some of the questions. Okay, so I guess my talk was very good because there's only one question. So question is, pre-op endoscopy, is it mandatory? As I said in the guidelines, so pre-operative endoscopy, if it's for a sleeve gastrectomy, the guidelines suggest that patients do have a pre-op endoscopy. Okay, I think, and for other surgeries, they said that it's at the discretion of the surgeon. So it's up to the surgeon to decide. Personally, I believe, so this is purely me, that every single patient should have pre-operative endoscopy. It's a very quick procedure. It takes less than 5 minutes and can really avoid complications intra-op and post-op. Okay, so I think we have no other questions. There's supposed to be a QR code that you have to take a picture of. Okay, perfect. So if you can please, in order to, if you go to the chat, you can click to register for the bariatric series sessions. If you take a picture of any of these QR codes, you can go in to fill out the questionnaire to get your CME points. And I think we have no more questions. So thank you all for attending. It's been an honor to start the series, and I look forward to the other speakers. So thank you very much, and have a good day.